Good morning, everybody. Welcome to Grand Rounds. Today, we're joined by Dr. Rachel Vreeman, who's a pediatrician and researcher specializing in improving care for children and adolescents living with HIV in resource-limited settings and building partnerships in global health to improve care and access to care. Dr. Vreeman became the chair of the Department of Global Health and Health System Design at the Icahn School of Medicine at Mount Sinai in March 2020, as well as the director of the Arnold Institute for Global Health at Mount Sinai. She's also a professor in the Department of Pediatrics. Dr. Vreeman chairs the Global Pediatric Working Group for the Global International Epidemiologic Databases Evaluating AIDS Consortium, a cohort with patient data for 2 million people living with HIV worldwide, and long-term funding from the National Institutes of Health, and serves on the World Health Organization's technical advisory working groups for both adolescent service delivery and child survival. Since 2004, she has worked within EMPATH Kenya Working Partnership, supporting development and research within an HIV Care Program caring for over 200,000 people living with HIV at 400 clinical sites in Western Kenya. A very warm welcome to Dr. Vreeman.
Thank you so much. Let me get my slide sharing underway here, and then I will talk more. All right, terrific. I'm going to assume that that's working for everyone. Great. So thank you so much for having me here. I really hope that this can serve as an introduction and really a welcome to all of you joining us into what we are embarking on in the Department of Global Health and the Arnold Institute for Global Health. As mentioned, my name is Rachel Vreeman. I am a pediatrician, so the honor of being at the Department of Medicine's Grand Rounds is always a special one in that way. And I'm going to talk today about partnerships. I've titled this Walking Together Research and Partnerships to Optimize Global Health. And I think you'll start to see as I walk through what kind of partnerships I'm talking about. Of course, my disclosure, I don't receive any financial support from any companies related to products or data presented. I do have several federal NIH grant awards that are listed there. So in our objectives for today, as I mentioned, I'm really focused on partnership. I want to help you walk with me through what I believe to be the critical components of global academic partnerships that generate impact for health. And I'm going to do my best to convince you that these are really evidence-based ways that we can play an incredibly important role in impacting health globally. I'm also going to talk about some of the factors associated with successful models of chronic disease care for vulnerable populations. And here we go. So I wanted to start with an excerpt from this article, one that I found really engaging and perhaps a bit provocative in its start. This was an article from 2019 written by Dr. Madhu Pai, who directs the Global Health Institute at McGill University. As you can see, the title is Global Health Still Mimics Colonial Ways. Here's how to break the pattern. And here's how Dr. Pai introduced this discussion, which I thought was really an excellent way to introduce discussions of global health and what we are trying to do and what we are not trying to do. So just to read a little bit from the article, imagine this scenario. A couple of newly minted Master of Public Health graduates from an African university, say in Rwanda, land in Washington, D.C. for a 2-week visit. They visit a few hospitals, speak to a few healthcare workers and policymakers, read a few reports, and write up a nice assessment of the U.S. health system with several recommendations on how to fix the issues they saw. They submit their manuscript to the American Journal of Public Health. Now, can you imagine the journal even sending it out for review? And even if the paper did get published somewhere, would U.S. health researchers take it seriously? He adds the important note, they should, I suppose. After all, the broken U.S. healthcare system needs all the help it can get. But clearly, it's an impossible scenario, yet American graduates land in low-income countries to advise them on global health issues all the time. I'm going to stop reading it there, but I think that for many of us, I would imagine that this scenario might ring a bit painfully true when we think about how we've been engaged in global health or how we've seen global health engagement from the perspective of those of us working in North American institutions get carried out. My hope today is to talk about a different kind of global health engagement, a different kind of global health partnership. This is a proverb, a motto that we hear often in East Africa, where much of my work has been done. It's usually said in Swahili, but the English translates to, if you want to walk fast, walk alone, but if you want to walk far, walk together. And I'm going to have this as our guiding proverb, our guiding motto, as we talk about how it is that the Arnhold Institute for Global Health wants to move forward in global health partnerships, what our next chapter looks like, and what it looks like for us to try to work together in partnerships that would allow us to walk far. Our vision at the Institute is that better global partnerships build a healthier world for all. Of course, this begs the question, what do I mean by better partnerships? So this is the model that we would posit for our global partnerships. First and foremost, we start with patients and community health needs and priorities. In these engagements, I actually think it's really critical for us to have close, individual, long-term engagements where we're really trying to dig into community voices, needs, what the priorities are, and to listen and learn locally as much as possible. Then we start this process of trying to figure out what evidence-based solutions might be applied to these needs and priorities, whether that's traditional research or engagement through big tech, through social entrepreneurs, and so on. Now, these first two steps are often where a lot of global health work, including in really incredible and productive global health centers and institutes, stopped. They engage with needs and priorities, and then they do their best to work collaboratively around evidence-based solutions and to move that evidence forward. And as a researcher myself, this is absolutely what I think the ideal work of clinicians, researchers especially, often is. But we're positing something bigger here because we have a bigger aim. So what we would then propose in this model is that particularly as an institution, we start to engage in a deeper kind of institutional counterpart relationships, not just relationships between one faculty member and another, or a handful of people in one department and a handful of those at another department, but that we really bring together academic partners such as medical schools, health system partners such as the teaching and referral hospitals with which academic medical centers are typically closely partnered, as well as government partners in the public health sector particularly. We would propose that these counterpart relationships, this kind of partnership, really be guided by a vision where we're trying to build long-term partnerships together with commitments together for the long term. We're very keen on trying to identify and really support mutual benefits. These partnerships should very much be for the benefit of all involved. Certainly there may be different benefits for each partner that they are seeking, but we're also aware that there are imbalances in resources, in power, in privilege, and we need to counteract those from a systemic and institutionally baked in level to really grow the benefits on each side. And I think that's where these institutional partnerships can start to effectively put in place the structures that do combat the influences of colonialism, that do combat the ways that systemic racism permeates our medical structures and so on. With these partnerships, we would propose that we're typically trying to address the tripartite mission of academic medical centers and their public health partners. This would be to advance care, research, and education. When we talk about mutual benefits, we are all usually looking to try to grow in these three areas, and that's where we can figure out how, as long-term partners, we can do this together. I believe that it's in the context of these kinds of partnership relationships that we then really start to see impact at scale, that we don't just have, great papers and, specific research findings moving forward, but we actually start to see care models being changed, national and global policy impact and changes in how countries, how nations are having guidelines to move forward, the kind of things we're trying to recommend, and also how we begin to generate big data that can improve care and also generate more impactful research as well. And out of all of these mechanisms of partnership, then we start to see improved health at a greater scale. And that's really, it's that scale, that broader impact that we're particularly after. Our goal then would be that we would start to see that we can deliver and sustain effective healthcare services together, that we can reduce health disparities and address the social determinants of health, that this model would help us develop and strengthen human capacity for all of these partners, that we would advance research that's improving health, and that we would strengthen each of the partner institutions. Currently, at the Arnold Institute for Global Health, we do see a big part of our mission of what we're here to do at the medical school as building and supporting the infrastructure for these kind of partnerships in which the other parts of the medical school across the various clinical departments and specialties can then engage in care, in research, and educational opportunities. This shows where we're currently focusing our efforts in Queens, in Ghana, in Kenya, and in Nepal, and I'm going to talk more about these. I feel though, as a researcher and as someone presenting this kind of model, I would hope that you're asking, what is your evidence for this kind of partnership? Why do you think that this kind of partnership structure might work to bring impact forward in the ways that you're describing? And to answer that question, I'm going to bring us to Kenya for a little bit. I'm going to talk in a bit more detail and at length about what we call the EMPATH Kenya partnership, the strategic partnership that we are, as Mount Sinai, engaged in Kenya with a number of other partners. And this is a partnership that has really grown in and developed in this kind of model that I've laid out. This is a partnership that was established more than 30 years ago, initially by Indiana University School of Medicine with the Moi University School of Medicine in Kenya. And I want to talk about how this partnership embodies some of the principles that we are trying to not only engage with in Kenya, but also to replicate and move forward in our other strategic partnerships that Mount Sinai is building. EMPATH is an acronym standing for the Academic Model Providing Access to Healthcare. EMPATH defines itself as a global network of academic health centers that collaborate with host academic institutions and their public sector health systems to support holistic, sustainable healthcare systems around the world. I think you can see in that vision sentence the elements actually of the partnership model that we've laid out at the Arnold Institute. EMPATH seeks to enable health professionals, scientists, and trainees to study and serve together through care, training, and research programs designed to respond to the needs of the population served. The EMPATH motto is to start with care and then do more. This is the group of partners engaged in this EMPATH partnership in Kenya. Our Kenyan partners are Moi University, the Moi Teaching and Referral Hospital, and the Kenyan Ministry of Health, and then engaged with a consortium of North American partners that refers to themselves also as the EMPATH Consortium. This consortium was initially put together by Indiana University, as I mentioned. Mount Sinai has been a part of this consortium for quite a number of years, and each of the institutions in this consortium not only agrees to partner with these kinds of principles and this vision for mutual benefits, for sustainable long-term institutional partners, but takes on a responsibility for moving forward care, research, and education in particular disciplines, while also opening up care, research, and educational opportunities for members of their institution across a broad range. Now, this is where I start to highlight, this is just a few summary details, but the evidence for how EMPATH with this model has been able to have incredible impact in Western Kenya, where the partnership has been located. The EMPATH partnership currently serves more than 8 million Kenyans, providing Kenyan-led HIV specialty services, NCD care, such as for hypertension, diabetes, anticoagulation services, I can go on and on, mental health services, oncology services, surgery, mental health, maternal, newborn, and child health services, and a population health initiative. For example, there are 200,000 people living with HIV that receive care through EMPATH, including free antiretroviral therapy, and there are 400 clinical sites in which EMPATH partners with the Ministry of Health to provide these kinds of care services from the community all the way up to the referral hospital. On the research front, I had the privilege before I came to Mount Sinai of being the North American Director of Research for this network for the 5 years before I came to Mount Sinai. In this research network, we see a robust collaboration where 20 universities are accessing core infrastructure, such as laboratory facilities, local IRBs, a massive informatics data platform in Kenya, and research working groups that span from pediatrics to oncology to mental health. This research network has garnered almost $190 million in research awards, specifically almost 90% of which is from the NIH, and published more than 1,000 articles. And on the education front, this partnership has collaboratively trained almost 3,000 Kenyan and North American individuals. That includes medical students, residents, fellows, as well as some junior faculty members with specific subspecialty training opportunities. The program has trained more than 1,000 community health workers in Kenya to become specialized in delivering care and following up with patients across a variety of health conditions. And more than 100 faculty members are currently collaborating in this endeavor, with excellent rates of Kenyan faculty retention in Kenya in particular, which really speaks, I think, to how this partnership has been able to grow capacity and create opportunities for the local institutions to really flourish. In addition, in some ways, kind of continuing to do more, even beyond what we would think of traditionally as care and research and education, this academic medical partnership has moved forward critical parts of universal health coverage, including what it looks like to empower Kenyans with more stable financial support. Through training and support for income generation, more than 30,000 group members are involved in income generation projects and savings and loans programs. Groups that are specialized around farmers have sprung up, which include 85 groups currently that have produced and sold 20,000 metric tons of food in this area. More than $5 million US has been mobilized in Kenya by Kenyans in these small savings and loans programs. And we've also been able to partner with the Kenyan Ministry of Health and Ministry of Finance around a trial for an innovative national health insurance model in the EMPATH catchment area to really try to examine what it would look like to provide sustainable financial support for preventive, primary, and chronic care. I'm going to dig in even a little bit more deeply to this Kenya partnership and tell a little bit of my own story in this. And I do this to give, again, one specific example, but to show how these kinds of partnerships can really provide an incredible venue for faculty members to grow in their own specific career trajectories, as well as to have impact through care in research and education as well. These are actually two pictures from the early 2000s when I was, of course, much younger, and I spent my first 2 months working in the hospital wards in Kenya at Moi University at the Teaching and Referral Hospital as a pediatrics resident in one of the EMPATH resident rotations. And at that time, the wards of the hospital for pediatrics, as well as for adult medicine, were filled with dying patients. And these patients were dying of HIV. The epidemic in Kenya was really horrifying. There were no antiretroviral therapies. Those medicines were not available in country at that time. And we were just beginning to start to be able to test and to dream more effectively about treatment. I had the opportunity in this partnership in that very year, as the EMPATH partners received one of the first USAID PEPFAR awards, to be kind of on the ground with what it would look like to start to try to scale up an effective treatment program to provide care for those living with HIV. This was a program, again, very much born out of the partnership by Moy University with Indiana University School of Medicine. And I ended up doing a health services research fellowship based largely in Kenya, and then joining the faculty at a time where I was able to contribute to what it looked like to build up the pediatric portion of this HIV care program. This program started in these early 2000 years with just one room at the referral hospital, and grew, as I said, rapidly over the course of just several years to include more than 400 clinical sites caring for over 200,000 people living with HIV in Kenya. This HIV treatment program continues to be a very robust one. It's led by about 800 Kenyan clinicians, physicians, physician assistant equivalents or medical officers, and nurses, as well as, of course, social workers, nutrition counselors, and others who provide really robust HIV care services for families living with HIV across Western Kenya. And it's been my great privilege to see HIV transformed from an emergency that was, particularly for me, killing the children I was seeing all around, to one where I now am primarily taking care of adolescents and young adults who've been living with this infection for their whole lives and are now able to really walk into a thriving, healthy adulthood. But again, the question in this is, as I said, sort of the motto in this is you start with care and do more. And for me, that part of doing more, or what this has looked like in terms of the process of trying to support and build up this care system, has been growth as a researcher related to HIV care and what it looks like to provide the most effective long-term care services for HIV for children and adolescents, not only in Kenya, but in similar settings across sub-Saharan Africa. As some of you have likely heard this year, 2021 marks 40 years since the first case reports of HIV emerged in the United States. And as we look back at this anniversary of 4 years of living with HIV, we're certainly struck by not only the incredible successes of being able, again, to transform this infection to a chronic disease, but also this question of what challenges remain. What does this look like? And for children and adolescents, as I was able to point out with some collaborators in this article that we put out this year in the Journal of the International AIDS Society related to this struggle, there are some really significant challenges that remain for children and adolescents. Just as framing, and again, to look at what this research partnership and this care partnership and this partnership together woven has been able to do, a bit of framing for what the current state of HIV is for children and adolescents right now. So we currently have about 1.8 million children under 14 who are still living with HIV globally. About 90% of them live in sub-Saharan Africa. This includes about 2 million adolescents globally who are living with HIV. And in contrast to adults, where we're approaching 75 to 80% of adults with HIV being able to access antiretroviral therapy, only about half of the children living with HIV receive ART. And unfortunately, even for those accessing ART, children on ART have worse viral suppression than adults. And it's even worse for adolescents. Their adherence and their viral suppression both are worse than either younger children or adults. And perhaps not surprisingly, they are the age group with the highest HIV-related mortality. In fact, the only age group for which HIV mortality continues to increase rather than decrease. Slides don't want to go. In this picture here, I'm with Dr. Winston Mandiko, who has been my close collaborator, my co-PI ever since 2005. And our guiding question throughout these years has been, how do we help HIV-infected children, adolescents, and their families sustain successful HIV treatment for their entire lives? Our research question very much guided and hand in hand with our efforts to try to build up an effective clinical care system in Kenya to provide care for families. Our research has largely fallen into these 4 areas: adherence to ART, durable treatment strategies for children and adolescents, HIV disclosure, both how we tell children that they're infected with HIV, as well as how we support children and adults too, to tell other people about their HIV diagnoses, and then work in the area of mental health and HIV-related stigma. Again, we continue to try to do more beyond care. Before I talk about the research at all, I wanted to say a thank you to my large and incredible research team, at least large by my standards. This is a team that is Kenya-based. They have been incredibly productive and especially diligent throughout the last 2 years of the COVID pandemic, not only to keep our research work going and to launch new research projects, but really to have effective, close engagement and follow-up, and even going above and beyond to making sure the kids we're working with are getting medicines and enough when they're not able to get to clinics in the middle of lockdowns and so on. So a big thanks to my team that I wanted to put up front. Just to highlight a bit what this research has looked like, again, in the context of providing an example for how this kind of global partnership can create the infrastructure, both for care and also for research, that can really move forward incredibly exciting areas of inquiry, work that can be funded robustly by the NIH and other funders, and which answers critical questions for how we improve care for a specific need. So our work related to sustaining adherence to therapy for HIV began with in-depth qualitative inquiry and development of a conceptual model for pediatric adherence. We've examined diverse factors impacting the access to HIV care and to testing and to adherence to medicines, including conflict, orphanhood, HIV disclosure, HIV-related stigma, and mental health challenges. We've been able to develop and validate a culturally tailored adherence measurement questionnaire that's validated for ART adherence with children and adolescents. We first validated this in Kenya, then more broadly in East Africa, and then across several global settings ranging from South Africa to Thailand. We have launched and followed a cohort that examines adherence and viral resistance in about 600 Kenyan children who are on ART, who we've followed with detailed assessments now for more than 10 years. And we've also been able to specifically inform the global HIV treatment guidelines and service delivery for adolescents as a result of the research moving out of this partnership. We've been able to shape adolescent HIV care delivery both locally as well as globally. We've been able to incorporate novel drug resistance genotyping strategies that can be done more effectively in settings where resistance testing is not routinely available for clinical use. We've informed pediatric ARV dosing protocols, which are too seldom just extrapolated from adult dosing without PK and PD studies and looking at what the impacts of, say, malnutrition in children might be on ARV dosing. We've been able to test and then implement counseling interventions, peer support curricula, and peer navigator strategies. Of course, we've done a lot related to adherence measurement and support. We've validated an HIV stigma measurement for households that we're able to incorporate into our assessments. We've tried out mobile health innovations, both for adolescent counseling, for mental health support, and for using to extend peer support, a teacher training curriculum in the community to try to reduce HIV stigma within schools. And then we're incredibly proud of efforts that Mount Sinai in particular is trying to move forward related to developing an adolescent health center and adolescent-friendly services in Kenya. So we've been able to establish what we call the Rafiki Center of Excellence in Adolescent Health in Kenya at the Teaching and Referral Hospital and the medical school. Our goal is that this would be the first step with our partners at MOI in advancing an adolescent health initiative that would advance care, research, and training in adolescent medicine. Beginning with this innovative care model at the referral center, we hope one that can grow in in the model of Mount Sinai's incredible Adolescent Health Center, and then to ideally extend that capacity for providing care and support for adolescents to all of the 400 Ministry of Health sites with whom we partner in Western Kenya. These principles of adolescent supportive care, ranging from sexual and reproductive health services to mental health support, as well of course in specifics like HIV care and HIV prevention, that we really hope can move forward across Kenya. In the picture here with me on the right is Dr. Edith Apandi, who is a Kenyan pediatrician at Moi Teaching and Referral Hospital, who leads this adolescent health initiative and with whom I've been really privileged to partner. On the left is Jane Shimon, a nurse and clinical officer who's been a critical advocate for this work as well. Continuing briefly on the research front, our work has also continued to move. And again, if you remember the model I was pointing out, where how these partnerships together in a particular place, we believe then have the ability to grow to broader global impact. I think in both our research work and where we see things moving with our care delivery models, we start to see global involvement and global impact as well. Initially in Kenya, and again, this is using just the specific example from my own work, we were able to establish this Kenyan adolescent cohort. This is different that we've had an adherence and resistance cohort since 2008. And then we've had a cohort that's more broadly spanned across East Africa, following about 400 adolescents, again, living with HIV, but both engaged and disengaged in care. This East Africa cohort then served as a model for us to secure funding to launch a global adolescent cohort with support for the NIH and built on our global HIV epidemiologic data consortium, which the sites of which are highlighted in this world map here, where we're launching, hopefully by the end of this year of 2021, a global adolescent and young adult network, we call YANI, that will be following prospectively across each of the 6 global regions of IDEA. Other global cohorts under development from this work and these connections include a cohort to examine pediatric non-progressors with HIV, those who manage to keep HIV virus suppressed even without ARVs, as well as to really build up electronic medical record support as the basis for our national and international cohort data. And finally, I did want to touch on COVID and the specific impact here, because of course this translates across our global partnerships as well. So for adolescents living with HIV in Kenya, New York, and in our global cohort, we have been looking specifically at the impact of COVID. As you can imagine, this is a group with immune suppression, a group that generally has fairly limited resources. To have them separated from their peers and social support through lockdowns and school closures, to have them separated from their clinical services where they typically access their crucial antiretroviral medications. We've been incredibly concerned about what the direct and indirect impacts of the pandemic would be for this group. Early in 2020, we were able to launch phone-based surveys to evaluate the impact of COVID-19 and these lockdowns and so on the clinical, mental, and social health of adolescents from these various global locations. We've also been able to trial digital public health education strategies to reach adolescents and young adults with messages about mitigating and preventing COVID infection, more and more also to use to try to connect them with things like vaccine access. And as I think has been the case everywhere, we have been able to use this as well as a chance to really try to push forward models for using telehealth and mobile health strategies to provide care and to bring care to those who may be, unable to travel to the clinic as well. I did want to highlight for the group, while I have your attention, on December 1st every year, we globally celebrate World AIDS Day. This is a day to honor and consider and draw attention to those living with HIV worldwide. We're incredibly excited to host Mount Sinai's World AIDS Day again this year. And I wanted to just note that Wednesday, December 1st is coming up quickly. We would love to have anyone interested join us for this special virtual event. We're going to have a time where we really highlight Kenyan youth living with HIV and their voices and needs. And then our keynote speaker with whom I will be in dialogue is Dr. Linda Gale Becker, who leads the Desmond Tutu HIV/AIDS Center in South Africa and is the immediate past president of the International AIDS Society. I'm really excited for this conversation with Dr. Becker and hope that Mount Sinai will come together to really honor those living with HIV, those who have died from HIV, and to think about where we can continue to combat this pandemic as well as we move forward. And then finally, I've spent a lot of time on HIV and on this specific Kenya partnership, but I did want to highlight that the impact of this partnership, the EMPATH partnership in Kenya, has been felt across lots of different areas. I highlighted HIV, but the same has been true in terms of care, facilities developed, treatment services, educational opportunities, capacity building, and research in each of these areas, in cancer, in child health, chronic disease management, from diabetes, heart disease, to mental health, specialty care, including tuberculosis, malaria, and palliative care. Did want to highlight a few other Mount Sinai faculty, particularly from the medicine world. Dr. Lindsay Dow has been particularly involved with building palliative care capacity in the EMPATH partnership. Dr. Carol Horowitz has been part of the efforts to move forward chronic disease management, particularly in the community, and what it looks like to have nurses and community health workers delivering that care in Kenya. And Dr. Rebecca Roediger, one of the new members of the gastroenterology group, is starting to consider what it would look like to look not only broadly at GI-related disease, but specifically hepatic disease and hepatitis in this setting as well. The departments of psychiatry and pediatrics at Mount Sinai have had residents engaged in the EMPATH partnership. And again, the area for potential involvement is broad here. I didn't mean to neglect those in the bottom: women's health, surgery, economic empowerment, as I mentioned, and supportive services and infrastructure that range from mobile radiology efforts to pharmacy to legal advocacy and social justice efforts. So again, I think this is a model for partnership that not only are we thrilled to be a partner in at Mount Sinai, but really provides an evidence base for how we might move other global partnerships forward. So what does this look like when we think about what these global partnerships would look like that the Arnhold Institute is hoping to engage with moving forward in this new chapter? So obviously I've talked a lot about Kenya and these partners, but we are trying to invest in and support and grow 3 other global partnerships in this model that I've described with partners, with counterparts in each of these places: in Dhulikhel, Nepal, in Navrongo, Ghana, and in Queens, New York. The leads are shown here, and I'm going to walk through each of these. For time, I'll keep it more brief with these, but again, our hope is that, while this partnership in Kenya is certainly the most long-standing of partnerships in this model, we hope that applying these same principles to how Mount Sinai partners globally with partners in each of these places will yield similar results over time. So to talk a little bit about the partnership in Ghana, here our close partner is the Navrongo Health Research Center, where Dr. David Heller and Dr. Vreeman have been partnering in an effort to expand the workforce and delivery of care for chronic conditions. I'm incredibly excited to highlight this work, particularly because our team from Mount Sinai that ranges from the Department of Global Health to the Office of Global Operations, with representatives from care, education, and research, just returned on Friday from our first in-person site visit since the pandemic started with these partners, and really seeking to continue to understand how we can grow and deepen this partnership. The Navrongo Health Research Center has incredible public health capacity. For more than 30 years, they've carried out a health and demographic surveillance for this region in northern Ghana with rich data related to morbidity, mortality, causes of death. They've been particularly focused on expanding access to maternal health care, and not only and I'll talk a little bit more about what they've done in terms of moving forward community health. From this team, our global partnership leadership team in Ghana reflected here, which includes Maria Anyo-Rikea, David Heller, Khadija Jones, and Raymond DeBorrigo. Their statement is that together, this partnership hopes to expand access to community care for all chronic conditions across rural Ghana. Our partners at the Navrongo Health Research Center, as I said, have not only had this incredible presence through their demographic surveillance system, but they first developed and then have really rolled out a program for community health provision that's now been taken up by the Ghana Health Service and extended across Ghana to run these community health compounds that they're called, with nurse support and then supervising community health volunteers, particularly around extending maternal and child health care into the community. One is pictured here. And so the idea is to take this robust community health model that the Navrongo Center has been so engaged with, and to expand this program that includes implementation research, action, and capacity building, as well as their incredible resources for the data surveillance system. Oh, and I forgot to mention, but it was in that picture of the Navrongo Health Research Center. They also have a robust research capacity, including a clinical trials unit located at this site in Navrongo, where they're currently doing COVID vaccine testing, among other clinical trials. So leveraging their care expertise in care and research and public health delivery, and now trying together to adapt this community care model to include chronic conditions and to further develop the evidence base to improve care outcomes and policy. The dream is that we could train nurses together and community health workers that would provide access to comprehensive community care for more than 3,000 patients that they serve in this region. We also are trying to offer and structure in bilateral educational opportunities for clinical care providers. And we also visited with and see a future where we hope to link an additional collaboration with the Academic Health Center located nearby at the Tamale Teaching Hospital and the University of Development Studies, where other partners of ours from the EMPATH consortium are attempting to launch with these Ghanaian partners an EMPATH Ghana model as well. So we'd really love to bring together these same principles of partnership to not only deepen the impact in care and research and the educational opportunities with Navrongo and partners there, but also to link in with a broader effort across northern Ghana. Just a few, because we had such an incredible visit, and I would imagine there are questions related to the COVID situation. We were delighted to see in these community health compounds, nurses vaccinating community members for COVID. This is actually a nurse in the process of getting ready to administer a COVID vaccine to a community member. And you can also see an inset picture there from art suggesting Ghanaians get vaccinated and that it's safe and effective. We were incredibly happy to see, steps towards true vaccine equity and access being moved forward. And again, through this impressive and effective public health partnership. This is a snapshot of the Mount Sinai team that visited, again, that just came back last week, and with representatives from across global operations, global health education, research, and the Arnhold Institute for Global Health. Thank you to this incredible team, and of course to our hosts in Navrongo. I'll touch briefly as well on the Nepal partnership, where we seek to really transform rural community health in Nepal and to work closely with partners at the Kathmandu University School of Medical Sciences, the Medical School of Kathmandu University, and their Dhulikhel Teaching Hospital. Our goal is that we would be able to decrease maternal and child mortality in this region by trying again to improve community and comprehensive care and behavioral change programs led by community health workers, but then with access and a network of referral all the way up to the teaching hospital. The statement from our partnership leads here from Kathmandu University, Dulikhel Hospital, and the Mount Sinai lead, Dr. Duncan Morrow, is that together we dream of a world where no baby dies for lack of access to proven treatments. Health as a human right goes beyond political declarations. Innovation, evidence, and training are essential to translating policy to care delivery. So again, our partners really setting a goal for broad impact, for policy impact, and for national care delivery changes. So to try to strengthen the health system in Nepal, we are currently engaged in a community health worker model that seeks to extend care to the most rural settings in mountainous Nepal. The existing research portfolio led by our faculty members, Dr. Duncan Morrow, Dr. Sabitri Sapkota, and Dr. Sheila Morrow, include work on community-based strategies to reduce maternal mortality, to reduce under 1 year mortality, mHealth platforms to equip community health workers to provide care for conditions ranging from HIV to depression management. We're currently launching a clinical and educational needs assessment in Nepal with partners there around what would be the key priority areas for this partnership to move forward. We're also, with that, then planning where we could launch specific care and research initiatives in partnership with Kathmandu University. We're very close, we hope, to having a Mount Sinai faculty member who could serve as a lead with our partners in country in Nepal to engage closely around what these next steps would be and to support Mount Sinai's partnership growth there. We held a very successful virtual partnership summit in August of 2021 with stakeholders from our Nepal counterparts that included heads of department, the dean, the CEO for the hospital, and others. And we're looking forward to a site visit with these partners in Nepal that will begin in the beginning of December. We'll be traveling there on December 4th. So more to come on what's growing in the Nepal partnership. And then finally, a quick highlight related to our New York-based global partnership. In Queens, with our partners at New York City's Health and Hospital, Elmhurst Hospital, and Queens Hospital, led by Dr. Sheila Morrow and by Dr. Joe Massey, we initially developed a collaboration in March of 2020 with a goal of trying to strengthen and support the capacity of the frontline healthcare workers at Elmhurst and Queens to apply implementation science to treat COVID, which of course was incredibly overwhelming at that time, and then eventually together to develop not only a program to really support vaccine competence and combat the spread of health information, but to think about how we might together build a more resilient health system addressing COVID-related challenges and other specific challenges for the community in Queens, where we can work with our partners, who are of course also Mount Sinai faculty, but working with partners across Elmhurst and Queens hospitals to think about how implementation research can answer some of the critical questions that they have in the community there. The statement from the partnership leads is that together we are building a partnership to better understand and serve a globally diverse and vulnerable population and to be better prepared for the next pandemic. Right now, this particularly looks like what we call the Cure19 Collaborative Research Group. This is a research group that was initiated, as I mentioned, in March of 2020 to try to foster COVID-related research and care delivery improvements in Queens in specific. This group has begun to focus research around reproductive and child health, around people living with HIV in the COVID pandemic, and around the social and environmental determinants of health. We were able to launch launch a pilot grant program for starting and sparking collaborative research efforts related to COVID and this is for collaborators across Mount Sinai, Queen's Hospital, and Elmhurst Hospital. The first 4 pilot awards were given this year. You can see they range from the environmental and neighborhood impact of factors on COVID-19 outcomes, community healthcare workers and their role in promoting vaccine equity and access, how maternal COVID vaccination impacts passive infant immunity, and then questions related to opioid overdose and risk factors during the pandemic. We've been really delighted to be able to support this collaborative research and care group. The group meets typically weekly, and we very much welcome anyone interested in collaborating more closely with the Elmhurst and Queens partners to join that group. We've also been able to launch work led by Dr. Sheila Morrow to adapt a model for doula care to support pregnant women, postpartum women, and their infants for the Queens population. And not only what that looks like within this specific population, working closely with several community-based organizations around that adaptation, and what it looks like to implement this kind of care model in the pandemic and to tie it effectively into the public health system. I might note related to the pilot grant program that we anticipate the RFA for a new round of these pilot grants to be coming forward in the next 1 to 2 months. So be on the lookout for that if you have ideas or want to try to launch work in this area. We very much welcome people across Mount Sinai to consider sparking collaborations in this way. And then finally, a collaboration and partnership that does not localize to one specific country, but very importantly is something that spans across our global partnerships. You've probably heard in what I've been saying that our group and our global partnerships do emphasize health system design, specifically around community health. And around each of our partnerships, we have work going on looking at how community health workers or peer health workers can contribute to advancing universal health coverage. And we think that's very possible when these people, these individuals are set up well for success. We're delighted to be able to host in our department one of our faculty members named Dr. Madeline Ballard, who directs a group called the Community Health Impact Coalition. This is a coalition that operates in more than 40 countries, tying together nonprofit organizations across 40 countries that support community health workers. As a coalition, as a collaboration, not only do they support the work of over 50,000 community health workers globally, but they work together to do research that identifies the practices that lead to quality healthcare delivery in the community and to help accompany partners to adopt those practices, whether at a community level or at a government policy level and then globally. I hope that this is an engagement, not only that I have every intention, of course, of continuing to really support as best we can the Community Health Impact Coalition, but also I would love to see Mount Sinai continue to develop really robust expertise in global community health and what that might look like, perhaps as a center or similar. So finally, where does this leave us? As mentioned, I became the chair of this group, and we've sort of launched this effort in March of 2020. Of course, the pandemic does play a role in what we're able to get done. But I am pleased to report to the group that we do start to see signs of where we're having impact with these models of partnership in care, education, and research. On the care front, where it's really related to how well we can partner and support with our partners, with counterparts. But in those efforts, we have 50,000 community health workers being supported through the partnerships and the work of our faculty. We have 15,000 adolescents living with Kenya for whom we very actively support their comprehensive care program. And across our specific strategic global partnerships, more than 12 million people receive care. In research, as we've launched our department as more of a research-focused department with faculty seeking to develop as investigators, we've seen a 170% increase in our grant funding since the beginning of 2020. 2 of our faculty members have received NIHK or Career Development Awards in the last year, which we're really proud of as a young and relatively small department that does seek to grow up effective researchers as well as clinician researchers. We have 22 research studies collaboratively underway, and we've had over 40 publications in journals since that time. And despite the limitations of COVID, we have still been able to provide educational opportunities for 20 students during this time. And in all 4 of our global partnerships, we seek to establish bilateral educational opportunities. I'm going to stop here. I realize I see some questions have come up in the chat, and I'm sorry I had a hard time seeing them while I was screen sharing. So let me turn my attention to them, and I'm happy to start to try to answer those. But let me maybe stop screen sharing and let's start looking at some of the questions as well. But please note there, my email is there. You're welcome to reach out to me. And many, many thanks to both our global partners who I've tried to highlight, although it's been a whirlwind, as well as to the incredible staff and faculty of the Arnold Institute for Global Health. Thanks.
Thank you, Rachel. That was terrific, Rachel. Yeah, there are questions. Do you see them in there?
Yeah, I do. And again, sorry for not seeing them as I went. So, the first one there about, could this model be applied to the US? I absolutely believe so. And I hope that, as I'm thrilled that we've even though it grew out of sort of dire circumstances, in trying to support more robust collaboration with Elmhurst and Queens, with some of these same principles of how we engage with our global internationally located partners. I hope we already start to see ways in which our local partnerships could advance the same kinds of outcomes. And I absolutely believe personally that as the US thinks about how to develop and deliver universal healthcare, how to reduce disparities, how to bring effective innovations into resource limited settings in the US, that our global health research, global health experiences should absolutely be brought to bear on trying to answer those questions effectively. I know I talked a lot about, I felt like with children and adolescents with HIV, which I could talk about all day. So I'll try to stay quickly here. But, we see all of those questions mentioned related to, why do children and adolescents do worse? Is it lack of drugs, lack of effectiveness, lack of adherence? It's all of the above. So children have less access to drugs. They have fewer regimens available in most resource limited settings. In most settings, we don't have more than 2 regimens available for children and adolescents, but yet we're looking at a lifetime on ARVs. Children actually overall do an incredible job, their parents, particularly when they're young, of trying to maintain adherence. But when you're talking about decades on these medicines and with lots of challenges to them, it's of course hard to not see resistance start to evolve as well. And some of the newer regimens that prevent resistance to HIV from developing are much less accessible in many global settings as well. So there are a lot of challenges. All of that being said, we know how to prevent children from being infected with HIV. If we could truly test and treat every person who is pregnant and who is living with HIV, we could eliminate child infections. And that is really my dream. I hope to be a pediatrician that no longer works on HIV. But we are unfortunately not there yet. I didn't mention as specifically collaborations or partnerships with traditional NGOs or corporations. That is an astute point. We do, through the Community Health Impact Coalition, have more of an engagement with a broader set of NGOs. I would say, in this model that I've pointed out, we think that there's a critical and really high potential that can be achieved when academic health centers come together with academic health centers around our shared goals to advance care, to move forward research, to be the trainers of the next generation of medical professionals, across a range. I think it's typically critical, vital that we have government partners engaged in that. And that's kind of where that part is focused. Now, that being said, to sustain this infrastructure, to make some of this possible, I think there's and also to catalyze, the development of new innovations and all of the typical things we want to do in research. I think there's an incredible role that corporations, particularly those committed to social responsibility, can play to really support these partnerships. In the Kenya partnership, I didn't touch on it that much, but there has been a long history of support and engagement, especially with a number of the large pharmaceutical companies, for providing particularly drugs that can then be used as efforts, for example, in mental health and oncology, in diabetes care, to move forward, so that as the research innovations, as the care models are moving forward, as kind of an initial catalyst to have some of the either medical technologies or medications needed, there can be a critical role for that there, as well as financial support to leverage. And often then there can be partnerships created too with the government partners for how things might be moved forward more sustainably. I'm going to skip to the last question there and then come back to the HIV ones. Wars and insurrections absolutely interfere with the ability to provide care in the same ways that pandemics do. We saw in Kenya at the end of 2007, there was significant violence and a lot of internal displacement in the country after a highly contested presidential election. And most of that displacement of several 100,000 people occurred in Western Kenya, right where our partnership was working. We saw in real time dramatic challenges for children being able to access ARVs. And once they returned to care, we saw significant drops in their viral suppression related to it, either from not being able to adhere to medicines in the midst of chaos or not being able to access medicines at different times and so on. And I think in some ways children are, as the phrase goes, like a canary in the coal mine for this. We often see the impacts the fastest for lack of food, lack of medicines, lack of stable care, and so on. So absolutely. And, and that's where, increasingly models that we can adapt rapidly to provide community-based care, to extend care beyond specific, health centers. Just as we've seen in the midst of the COVID pandemic here, we need to be able to apply those strategies globally, including us. I'm going to pause there because I know we're a little bit after the hour, so I'm assuming we probably need to stop. I should note that I'm incredibly excited about trying to move forward long-acting injectable ARVs for adolescents and young adults who are begging for them in settings like Kenya and routinely say they would much rather have those than the daily pills they have to take every day. But we don't yet have widespread access to that, but very much hoping that will really be a strategy for us to add to long-term HIV care as well. Thank you, everyone, for your attention and time.
Thank you, Dr. Vreeman. I knew this was going to be a great grand round, and you didn't let me down. It was terrific. It was a great introduction of your department to all of the Department of Medicine. I think very productive use of time, and really appreciate you spending it with us. So on behalf of the medicine, thank you very much for the grand rounds.
Thank you so much. I really appreciate the opportunity to introduce us and very much hope to meet more of you and hear from more of you in the near future as well. Thank you so much.